What's up today, guys? I'm over here at ISU School of Nursing. We're going to talk about some ABGs with the nursing students here. Cut to the intro. We go to 45-degree angle. We don't go kind of flat, so it's a little different technique there. We draw blood out. It goes into a heparinized syringe, keeps it from clotting. We only need about a milliliter of blood to run our test. And so, why does it have to be arterial blood? Might seem like an easy question, and it probably is, but it's okay. You can answer.
I don't know. Is it because it's oxygenated and like nutrient filled?
Yes, not nutrient filled as much. Oxygenated, yes. And the best thing is to explain to the patient, because they're going to say, lab just came in and drew my blood. Why can you not use their blood? They say that all the time to us. And we've got to redraw. We have to draw from the arterial system. And what I tell them is, we want to get a good picture of what your lungs are doing. So this blood's coming directly from your lungs, and it really is. Telling us how the oxygen's coming across and the carbon dioxide's coming across. If we drew venous blood, yes, we will get all the values, but they're going to be skewed because the blood's already been down to the tissues, dumped off oxygen, brought on a little more CO2, pH has changed a little bit, but mainly in the oxygen category, the PaO2 category, the venous blood's gonna be a lot lower because the body's doing what it's supposed to do, is dump off oxygen. So I always tell them, we wanna get a good picture of how your lungs are functioning right now. They tend to be okay with that. Now, just because it's an arterial stick does not always mean it's gonna be more painful. I've had many patients say that the arterial stick was less painful than the venous stick. And mainly because we're going such an angle through a lot of the epidermal tissue, and with the vein, you know, you're going more flat and you're going through a lot more nerves and whatnot through there. So just because it's an arterial stick doesn't always mean it's going to hurt more. We prefer radial also, collateral blood flow, but it is right close to the surface. And there's even times when we shouldn't, but we do. We can't feel a pulse real well. Almost everybody has a radial artery. Some people don't. You can almost pinpoint anatomically where it's going to be and hit it. So we also can use ultrasound to see that too. So those are the places we're going to draw arterial blood gas. Now let's get our results back. The reason that we like arterial blood gases in the hospital is because we have a really fast turnaround time on the results. So any type of code we go to, we get results in our desktop machine in about 30 to 45 seconds. And our iStat machine, which is handheld, is about this tall. We started using these the last couple of years. It comes back in about 1.5 to 2 minutes. Great information, especially if you're in an emergent situation like a code or a rapid response. So you get those results right there. It's not sending them down the lab and waiting for all this other stuff. It's like get them right now so we can make an intervention. So let's talk about some of the values you're going to see on a blood gas. Now this is going to start very simple, and then we'll kind of work into that. So first of all, we want to look at our normal values. So first of all, our pH. What's the normal value for pH?
7.35 to 4.5.
Yep,
7.45.
Yeah, I knew what you were saying. Okay, so there's normal for pH. This is really the only memorization part of it, is knowing these normal values, but that's really most of medicine. So PaCO2, also known as PCO2. Does anybody know what that stands for, first of all?
Percentage carbon dioxide.
Close. The P means something else. Is carbon dioxide? Yes. The little a, what does that stand for? Arterial. Good. Yeah, so this is arterial, and then the P means partial pressure. And so this is going to be a little funky because you're probably not used to measuring blood values in pressure. You're more like milligrams per deciliter or something like that, you know. So this is a pressure. So it's the partial pressure of CO2 in the arterial system. What's normal for that? 35 to 45. It's very easy. I put these in line just because you see your 3.5 and your 4.5, they're right here. So you know that one, you know the next one. Does anybody know what the units are on this one? It's a pressure unit. Yes. Millimeters Hg. Now you'll also see this written if they want to throw a curveball to you on a test, which you don't. No curveballs. That's too bad. They do in respiratory school. So my instructor they also call this TOR. So it's just another. It's the same measurement of it. It's kind of European-ish. So you can also use TOR. So you just be glad I'm not your instructor. I throw curveballs. That would be a great curveball. So anyway, millimeters of mercury, same thing as TOR. So this is partial pressure of oxygen in the arterial system. So PaO2, also called PO2. Sometimes they take the A off. It's just kind of assumed. Does anybody know what normal is for that?
80 to 100.
80 to 100. And I'll put a little star on it because it deserves a star. And this is the same. The star right here, because what the star means is on room air. So that's very important because the PaO2 value changes for whatever oxygen you have your patient on. So every time you see a PaO2 number, you give it 0 credibility until you know how much oxygen they're on. Hopefully we'll get to that part today. I want to put a little box around this dude because it has nothing to do with acid-base balance, but it is on every blood gas, so I'm going to give you that value. And the last one is bicarb. Now, what is your normal for bicarb? Take a wild guess. 22 to 26. Awesome. Milliequivalent per liter. I always get it mixed up, but I think milliequivalent per liter. So this is actually measuring more of a volume. You see, this is what you're kind of used to in your lab, looking at a volume of that bicarb. This is a pressure, this is a pressure. pH does not have units, so doesn't serve units. So the next thing we want to do, these are our 4 that we have to memorize. Really only for acid-base balance, 3 of them. So we'll take this PaO2 out. So the way that I help to name blood gases is you have to know which direction is causing an acidosis or an alkalosis. Now I think that you guys may call it acid or basic. Is that right? Acidosis, alkalosis? Perfect. Awesome. Great. That's my language. So if a pH is below 7.35, is it acidosis or alkalosis? Acid. Okay, cool. I'm just going to go through and name each one of these, okay? And this obviously is alkalosis. So, a CO2 less than 35, acidosis or alkalosis? Alkalosis, very good. And this was acidosis. So, above 45. Bicarb less than 22, acidosis or alkalosis? Less than 22. Nope. Acidosis, 50-50 chance, so. Okay. Now, that is, if you can memorize these parts, you can read a blood gas really easy. But that, I mean, that's kind of a lot to memorize. But still, if you can memorize that, and I'll try to relate it to something in a second. So, let's do our first blood gas, and we're going to talk about, and so this is not, we're not really talking about treatment yet. We're not even talking about really what the patient's going to be displayed like yet. We're just going to give you a number, and you have to tell us what type of blood gas it is. This is like, you know, when you're taking your nursing test and it gives you a blood gas and you need to say this is fully compensated respiratory acidosis. That's the first step, so learning that. And the second step, which I might see you at a later date for, will be talking about what treatments you're expecting with that type of blood gas. So let me give you the first one. So if Jimmy was working in the ICU and you were my ICU nurse, what's your name? Robert. So Robert's my ICU nurse today. And I came and we had a blood gas order, I drew a blood gas. I would probably give him the blood gas and it would look something like this. Let's see. Okay, so it's shorthand, but this is the way that we report them out. Each time you see a blood gas like this, this is pH, PCO2, PO2, and bicarb. So anytime you see 4 numbers starting with a pH divided with slashes, that's a blood gas. So we get a lot more on our blood gas, but this is the gist of it. Now remember, this dude right here, that's just looking at oxygenation, not acid-base balance, so we're not really going into that yet. So when I give Robert these values, I'm not going to tell him this is what it is. I might say, oh, I'll go get a BiPAP for this patient or something like that. But what you need to know, first of all, is what we call this blood gas. So you got to be methodical with this, because if you're not, you will probably, if you try to jump forward too fast, it makes it more difficult. So when we name a blood gas, we have 3 different options here. So if you can't keep up on the notes, it's okay, because I'll put this video out and you can watch it back. Okay, so 3 different spots. This spot right here is either going to say acidosis or alkalosis. This spot's either going to say respiratory or metabolic. And then this spot's going to be fully compensated, partially compensated, or uncompensated. So we read a blood gas backwards. I'll kind of show you how this is first. So we have that part. Let's go look at our gas now. So on each one of these, I want you to tell me acidotic or acidosis, alkalosis, or normal. Okay, for each one. So this one right here, acid. This one right here, we're gonna call this normal. Because we're not gonna mess with PaO2 right now. Normal, so between 22 and 25. So the first thing you do, you take whatever your pH says, and it goes right here. Okay, so right here, acidosis. This is going to go right here. Acidosis. We're working our direction that way when we're reading it. So let's go to this section right here. We have 2 options. We have respiratory and metabolic. So let's just take a guess. Which one of these numbers do you think is affected by the respiratory system? PaCO2. Okay. So that's resp, and then this is meta. I'm just going to put it up here. I've not done that before, but I think it might help. So the next thing, so we're reading this side right here. We need to find out which one of those, CO2 or bicarb, match what our pH is. So in this case, is it the respiratory side or is it the metabolic side? When I say match, I mean read the same. Acidosis, alkalosis, normal. So it's respiratory. So you get that? We'll do another one if you don't. It's respiratory. Acidosis, acidosis. This one's normal. These 2 match. Respiratory, acidosis. Now we need to go to this dude right here. So we got 3 options for this part. So the best thing to ask yourself in this section is the respiratory side, because you see this respiratory acidosis, is it getting help from the other system? Because what this should be is a balancing act. As one goes more acidotic, the body should make the other side more alkalotic by either holding on, in this case, holding on to hydrogen or secreting hydrogen through your kidneys. So it should balance act, and your goal is 7.40. Is the respiratory system getting help at this time? I would say no, because this thing is still normal. So one thing you could also say with this, if it's not getting help, the body will help. Sometimes on the bicarb side, it'll take hours to help. So this could be an acute issue. So when I say, since we're not getting help, we're uncompensated. Uncompensated respiratory acidosis, you could also call this an acute respiratory acidosis, because this is happening right now. And we'll talk about acute and chronic here in a second too. So this is an uncompensated respiratory acidosis. That'd be the correct read for this blood gas. CO2 is high, Acidotic, pH is dropping because of the CO2, and we're not getting any help right now, so we're uncompensated. So let's do another one. We'll describe these other ones in the next examples. Okay. Looks like a bad blood gas. I would probably actually come to Robert on this one. Because this is below 7.2, I would say, Robert, we have a panic value 7.18 on our pH. As part of our CLIA license, we have to document that we gave that to a nurse or a physician so that it gets reported. So I can't just draw blood gas, have a junky result, and just send it into the EMR. So I've got to report it to somebody. So it's a kind of a check and balance type of thing. So this would be a panic low pH. That's pretty serious on the pH side. All these numbers are estimates. So anybody on YouTube, these are estimated numbers. All right. So there's some people that come back to me, that's impossible. Well, these are estimated numbers. There's a Henderson-Hasselbalch equation you can do it, but I'm not going to do that. But these are good estimates. So let's go through our blood gas at the top. So acid, alk, or normal? Acid. Ooh, alk. Good, good. Normal high, we're going to call that acid. Okay, each time it's the same way. What does the pH say? Acidosis, right? Which one of these match the pH? Metabolic, right? Because the bicarb's also acidotic. Okay.
I'm sorry, why? I'm not sure.
That's okay. Yeah, I always lose somebody on this. Probably, you're not the only one. There's probably like 6 or 7. So, all right. So, when I go to this one, I need to ask myself which one of these sides, the respiratory side, which is the CO2, or the metabolic side, which is the bicarb, matches the same acidosis or alkalosis that the pH is. Because I have to give, if something has an acidosis, I've got to say it comes from one of the two systems.
Okay.
So which one of these two systems is causing acidosis?
Okay.
So that's why I would say metabolic.
Okay.
We'll do metabolic alkalosis. I put an alkalosis. If this was alkalosis right here, this is alkalosis, it would be a respiratory alkalosis because those match. So thanks for asking. I knew it was out there somewhere. It's every time, isn't it? I mean, for some reason, I can't ever get that one exactly right. So, okay, so the next question we have is, are we getting help from the other system? Yes, partial, good. We are getting help. So it's not uncompensated. It's partially compensated. Now, you say, Jimmy, why is it not fully compensated? Because to be fully compensated, you have to have a normal pH, okay? And we'll show you one of those shortly. So this is a partially compensated metabolic acidosis. Going back to the question again. Are we getting help from the respiratory side to help this metabolic side? I would say yes, because this is low. This is below, this is alkalotic, so it's trying to offset the acidosis a little bit. All right, so next level question. What kind of patient might this be? A metabolic acidosis. There's 3, okay.
Would it be diabetic?
Could be. Diabetic in what?
Like DKA?
DKA. That's one of the 3. DKA.
Would it be renal failure?
Yes, that's number 2. That's really good. That's really quick, you guys. Diarrhea. So you lose base. Yes, it could be. It could be diarrhea.
There's a lot of diarrhea, but
It is flaming diarrhea. It's like the worst ever. But you lose base from your butt. So if you lost base, you could go down on this. You probably get a more mild one, but yes, absolutely. Yes. Either vomiting or diarrhea, and you pick diarrhea, that's the right one. Vomiting's the other way, because you lose hydrogen. Yeah, so vomiting is going to cause more of an alkalosis. So diarrhea is correct. That's not one of my big three, though. I've got one more. It's a little bit more hard, and it's kind of maybe progressive over time.
COPD.
Nope. Maybe during a hospital stay, they come from a nursing home with a UTI initially, and they progress.
Sepsis?
Sepsis, there you go. Sepsis, you get release of lactic acid, and so your septic patient, this would be pretty bad off. And sepsis is not something that happens like this, it trends. And so this is where you guys can pick up being bedside nurses on, what's this patient's acting this way? Is it because there's something underlying that's causing it? So, DKA, renal failure, so kidneys aren't working, you're holding a bunch of hydrogen, you're gonna drop this number, and then sepsis. So describe to me, next step, describe to me what this patient might look like from the door when I walk in.
Like swollen,
Could be.
like if they had like renal failure.
Yeah, you're thinking renal failure, they definitely could be swollen. But not every time. There's something you should notice in this patient, and it'll be subtle. And it's one of your vital signs, and it's probably one of the most overlooked vital signs, I'll be honest.
Or the one that's like, oh, that's 16.
Yes, respiratory rate. So being a respiratory therapist, I'm very partial to respiratory rate. Now, I know we got a lot, 12, 14, 16, 20s that we ballpark, right? But it's actually really important, especially in your possible acidotic patient, to monitor respiratory rate. Do you think this patient's respiratory rate is gonna be faster or slower than a normal? Faster, yes. To get the CO2 down, it's gotta be faster. So you may notice your septic patient, maybe the first respiratory rate was 16, 4 hours later is 20, and now it's 24. Well, okay, just giving somebody a 24 doesn't give me a lot. But if I see a trend like that, there's a reason it's going to 24. So you go in, you determine they're not in pain, because that's one thing that increases respiratory rate. And they've got this really bad UTI, maybe leading to neurosepsis. When their respiratory rate starts to go up, you should in the back of your head say, their pH just came out of normal range now. That is their body's natural reaction to them going acidotic. So would it be a good thing to say, now Miss Smith, you need to calm down. We're gonna get her some meds to calm her down because she's breathing really fast right now. In that case, no, that'd be bad, because if she slowed down her breathing, her pH would drop even farther. Same thing with DKA. So the DKA patient we had, metabolic acidosis, we actually didn't do one yet, but let's say this is DKA. So what is the breathing pattern for DKA? Kussmaul's, yes. K for Kussmaul's for DKA. It kind of goes, can you demonstrate Kussmaul's for me, Robert? Okay, can anybody demonstrate Kussmaul's? Exactly right, fast and deep. A lot of people go, that's not it. No, it's two things to get somebody's CO2 down. Volume and rate. So, people may think I'm a little bit weird, but the first thing I look at when I walk in to see my patient for the first time, I look right at their clavicles, and I look at chest excursion. Chest excursion comes in really big, because although you showed that fast rate like that for Kussmaul's, if they're early in their metabolic acidosis, it may just be something like that. Just almost like a sigh breath. What that does, that's their brainstem telling them to take a larger breath. They don't know, it's autonomic. But their brainstem's telling them to do that to get that down. So 2 ways to get your CO2 down: large volume or fast rate. Once the volume doesn't work anymore, then the rate kicks in. But you're initially gonna see them you kind of see their chest excursion. I always look at chest excursion, because even if somebody says, I'm not short of breath, but you see them go, like, you see that excursion, they're working to breathe. Okay, so you wanna notice that from one time you see them to the next time you see them. Yep.
Is that what you see in patients with asthma?
Yes. Yeah, their chest excursion will change. Because with asthma, so their airways are like this. Asthma is swelling of their airways. So as their airways swell, it closes them down. So they'll go like this and try to hold air in sometimes and let out. So they're trying to really squeeze air down to the bottom. That's not always something they're thinking about they're doing. It's autonomic. They're kind of holding it and letting it out like that. Yeah, that's as they get more short of breath, they'll do that. They'll try to compensate. I'm feeling okay. I'm doing all right. I'm doing all right. And then they get to where they're not doing well really fast. So noticing the change in the respiratory rate is really big. Documenting increased chest excursion, or just patient having difficulty breathing because of what you can see from the door in the room. So
Why do you want your CO2 down?
in this case, because if CO2 is normal, so this is just if the CO2 is normal, let's say it's 38. It's 38 and this is normal. This pH would be, and this is the estimate, because it's not getting help. So the CO2 comes down to make it alkalotic to offset the acidosis.
Okay.
You sure?
I mean, yeah, I
Okay.
understand.
Okay, good. You didn't seem real sure. Okay. Let's do another one. I don't want to run out of time. Okay.
You know, take what, I mean, this is important.
No, it's okay. It's all good.
But until, yes. Do your best.
Okay. Okay, so very common blood gas that we see in the hospital. I'm going to definitely bring this with you, some panic values. Anything greater than 60 in the CO2 category is panic. So 95 is way up. So when I hand you this, if you see it come up in the EMR, this is going to be red, this is going to be red, this is going to be red. Because they're all way out of normal range. Okay? So let's go through and read this one. Don't get too excited about it yet. Don't panic. Acid. What's this one? Acid. Normal. Alk. Okay? So what is our blood gas? Can you guys do it now backwards?
Compensated respiratory acidosis.
Perfect. So, partially compensated respiratory acidosis. Did you watch my video? Or is she a respiratory therapist plant in here? She's not a plant for IT, is she? Yes. Dang it. I've had that before where there's been respiratory therapists planted in classes before. So.
Jimmy, I think you have a question.
Yes.
I know you spoke, but I don't get the fully partial and that's what I got.
Okay, cool. Let's do this one first. We'll take this off. So, we got acidosis right here, there. Which one matches? They both are acidotic, so this acid, this is alk. So respiratory matches this here. Now we want to ask ourselves the question, are we getting help from the other side? So is the bicarb helping in this case? Is it going the opposite direction, trying to offset this? In this case, is it helping? It's trying to, right? Because it's going the opposite direction. And so that's why we call it partially compensated. Now let me show you the next one. So if we took this and made this, hypothetically, 26, is that helping then? No, because it has to move from normal range. So when I say helping, I mean move from normal range. So in this case, it would be, what would you put there? Uncompensated. Okay? I will show you a fully compensated in just a second. What did I have that, 49?
Mm-hmm.
Yes.
Do it in a second, so wait.
Oh, yeah, fully. You want to see your fully one? Okay. Let's do it fully. I already told you what the answer is
So
going
that
to
was
be.
partial.
That was partially compensated respiratory acidosis, yes. Okay, so let's go through our blood gas. Normal, right? 735 to 745. That's considered normal. acid, normal, and what's this one? 32. Acid, alk, or normal? Okay, cool. All right. So we're like, all right, let's follow the rules. This is normal, but this is not really a normal blood gas, although the pH is normal. So we have to blame it on one of the two. So then if you got to blame it on one of the two sides, we're going to go by 7.40. Which side is 7.40 are we on? Acid or alk? Acid. Does everybody get that? Then which one matches acidosis? Respiratory, right here. Now, are we partially or fully compensated? Fully compensated, because the goal of fully compensated is you have to have a normal pH. And when you have a normal pH, fully compensated respiratory acidosis. This is our COPD patient on a normal day. Their body has done exactly what it's supposed to do over time. So as whatever's caused their COPD, so there's 5 different diseases. Emphysema, actually CBAVE is what I use. So cystic fibrosis, bronchiectasis, asthma, chronic bronchitis, and emphysema. So watch my other videos for that. I'll go through that another time. But 5 different diseases that cause obstruction. So they have obstruction to expiratory flow. That's why their CO2 is high. But it happens slowly over time. So their bicarb just slowly goes up and maintains that level to keep them at normal pH. The body is made. We were actually made in the beginning to trash our lungs. It's pretty cool. So the body will just compensate for that. So fully compensated respiratory acidosis. Yes, it's great to know this because this is not a normal blood gas and it's a baseline for them. But really right now, unless they look short of breath, look like they're working really hard to stay at this, we probably don't do a lot of extra treatment for them, even though their blood gas is out of whack because the pH is normal. Now, let's say they came in with pneumonia. This is their initial blood gas. Let me give you a progression of what their blood gas could look like. So I have them on 2 liters of oxygen, which is their standard they wear at home. So in 4 hours, I'm gonna leave that up there. In 4 hours, it looks something like this. Okay, so let's go through this blood gas. This is acid, normal-ish, and alk. So you see what happened these last 4 hours. They've not been ventilating as well. Their CO2 has went up, causing more acidosis, which has dropped their pH, and their bicarb's trying to catch it, but the bicarb moves very slow. So it will go, the kidneys move very slow in trying to catch it. So right now we have what is this blood gas? We're gonna read it.
Respiratory acidosis.
What'd you say?
Partial comp respiratory acidosis.
Partially compensated respiratory acidosis. Perfect. In this case, I would call this acute because we're out of normal range, on chronic because this is their blood gas initially, so it's chronic respiratory failure because their CO2 is chronically high. But this is acute on chronic issue. So do we help fix this? Yes. Do we put them on a ventilator for this? Probably not. Probably something more like a BiPAP to help them ventilate more, get them through this exacerbation. So this is what it will progress to if their disease process tends to get worse with an acute process like a pneumonia or something like that. So you understand that part?
So how sudden does that occur, like the change?
So very quickly. CO2 can change within minutes and bicarb just takes hours. So CO2, well, let me show you another gas real fast. Let's say this could be 15 minutes. It really could be. So if this patient, this is hypothetical, but let's say this patient came in with this blood gas, they came in with chest pain, we think it's pneumonia. And all of a sudden they have cardiac arrest. So they have cardiac arrest in the ER. We start CPR, I go in to draw their blood gas, 5 minutes into CPR. We'll just say this dropped. I'm just gonna put it's dropping. And then let's do this. Okay, doing CPR, very common blood gas to see. As soon as somebody's heart stops and their kidneys stop functioning, their bicarb drops like a rock, really, really fast. Okay, because they just keep all this hydrogen floating around in their blood, so it drops their bicarb. So this is acid, acid, low acid. Well, what the heck do we call this? This is a bad day. Okay, so right now, acidosis. So we've got to go to this one next, but they're both respiratory and metabolic, both are affecting it, right? And that is why your pH drops so fast, because this is system failure right now. It's not doing at all what it's supposed to do. I'm doing CPR on them. So we call this a mixed acidosis. So that's where you leave it. There's no compensation. When you say mixed acidosis, both systems are failing. Your pH is super low. Right now, when I see anything this low, I just think of every organ in their body is like on a frying pan. It is that acidotic and it's causing that much damage. So we need to get this back to normal as fast as we can, either to resume circulation, ventilate them, put an endotracheal tube in, because when I put an endotracheal tube in, I can take over this dude right here and I can control it by however I ventilate it. So I'll do that first, and then we assess, trying to get their heart rate back. We might give them some bicarb in a code case. Other times when bicarb's low, we want to treat the cause of the bicarb. So is it the DKA? So we treat the blood sugar. Is it the sepsis? So we can slowly treat that. Or is it renal failure where they might need dialysis for treatment? So in a code situation though, we intubate, usually start a CPR, then intubate quickly so we can get this dude under control. We can blow the CO2 down, at least get the pH to come up some to a closer to normal level. Because if I go, and do you know what any of your code medications are that you might deliver in a code? Epinephrine, amiodarone, you learn all these things. Anyway, if I dump them into blood that's anywhere close to this 705, well, that's arterial, so venous is probably even lower. They're not going to function appropriately. They're made to function in blood that's normal pH. So I've got to get the pH so my medications will actually function for my code. So yes, this can change extremely fast. 5 minutes. Bicarb can only change as fast as if you code and your kidneys just totally shut down. Stop getting perfused. So, questions about this? It's a lot of information in a small amount of time. Do you want to go, and we go over PO2 or not today? Probably too much for today. Let's do a couple more examples maybe. You guys okay with that? Okay. Actually, I'm going to go a little lower now. Okay, so look at it, break it down, go through each one. Acid, alk, or normal. Okay, I'll tell you this is not a normal blood gas. You can see that by some of the values. So let me go through, while you're looking at that, let me go through this and do it my way. So this is normal. This is alk, normal high, acid. This is not normal, so which side of 740 am I on? Acid side. So I'm going to go over here. Acidosis. Who am I going to blame it on? Metabolic, because that's acidosis also. And then what would I put there? Fully compensated. Metabolic acidosis. So you haven't seen your patient yet. You just got a report. The RT says, here, I need to give you this blood gas. I'll hand it to you. What's your name?
Ashley.
Ashley says right on your computer. So Ashley, here's your blood gas. You walk into the room, and they have this blood gas. What do you expect to see? If you see a CO2 at 20, you should expect to see one of two things. Either fast respiratory rate, or they're taking breaths like this. Every breath looks like a sigh. It looks like they're almost like a yawn, or they're just taking a large breath each time. You're like, what is the deal with that? And you can ask them to stop, but their brain is telling them not to. So you're expecting an elevated respiratory rate. So if you want to sound really smart, you say, well, get the blood gas. You're like, so what's the respiratory rate? They go, what? I've been documenting 16 for the last 12 hours. Like, no, it's not 16 anymore. So yes, people do that, unfortunately. So, fully compensated metabolic acidosis. All right.
I think Robert has a question for you.
Sorry, so if PCO2 is high, are they not breathing?
They're not well. So there's two different aspects to this. There's ventilation and there's oxygenation, and they're absolutely separate. Ventilation is getting rid of CO2. Oxygenation is getting oxygen in.
Okay, so are they not ventilating?
Yes.
When it's high?
Yes.
So what does that look like?
So what does it look like? A couple different things. They could have a low respiratory rate. So for you or I, we don't have lung disease. So if somebody gave us a large dose of an analgesic medication,
Okay.
then our respiratory rate was slow, below normal, let's say 8 or 6, our CO2 would start to rise. So low respiratory rate, or the main one we're gonna see is they just can't get air out. So they have obstructive lung disorder. So what obstructive lung disorder looks like is this. So you have your little alveoli like this, and usually you take air in and air goes out. With emphysema especially, you get weakened in this airway. So you get air in, but when it goes back out, this collapses and it holds air in. So then you take air and you don't get as much out. So then you get these large over-distended alveoli. We call them blebs. When they get really large, that's why the COPD patients, obstructive lung disorder patients, have a large AP diameter of the chest, because they've hyperinflated all of these, because they have weak airways. So they can get air in, they just cannot get it out. Well, what happens is your CO2 builds up in here, that goes across your arterial system, and that's how it reads out on the blood gas, because they have a high CO2. So you can do that over time. If you go up a point or two every year, your body will compensate for it. So that's why people are like, oh my gosh, I got diagnosed with COPD. Well, it's not like you just started smoking yesterday and it happened. You've been smoking the majority of your life, and now they just finally did a blood gas to tell you that. But it's not always smoking. That's directly related to emphysema. But it happens over time, and people usually don't realize it until they get sick, and then somebody does a blood gas, they do a chest x-ray, or do some other tests, and they're like, oh my goodness, your body's been compensating for this obstructive lung disorder for all these years. So that's what would cause it. In most cases, it's not a low respiratory rate. In a healthy patient, it's poor lung function. All right, so I need to do another one here. Okay, this is a very common one that we do. Let's see, like we have to do a blood gas before somebody has open heart surgery. So we have usually a healthy patient coming in. We do a blood gas, they have open heart surgery tomorrow. This is a very common blood gas that we get. Now, we give this to the anesthesiologist, they're like, no big deal. Because they want to see a baseline. They're gonna put them on an anesthesia machine, which is essentially a ventilator. We're gonna put them on a ventilator upstairs and they come upstairs. So let's go through this one. Very common blood gas. It might even be a blood gas that you guys can have if I was gonna do a blood gas on you. So, alk, normal, high, normal. Alkalosis, respiratory or metabolic? Good, good. Fully, partially, or uncompensated? Uncompensated, no help over here, right? Tell me about this patient. This is acute hyperventilation. So if I come in and I'm gonna do a blood gas on Ashley and I tell her about all this, and you're like, you have tattoos. Which usually means you're going to like, say a blood gas hurts way worse than it usually does. I don't understand that reason. But usually people that have tattoos,
Terrified needles.
there you go, exactly right. That's exactly what they say. They start breathing fast. So I go in and start feeling, I'm like, that's a good one. Hey, Jimmy, RT student, you want to try this one? I don't usually say it in front of the patient, but I have an RT student try it because you know they got to try and get good. So they try it and they go in and like digging around in there. It does happen. You got to dig sometimes. So, well, if you're good, you don't. But you go in and you're like, this is like painful, and she's going like that. That's all it takes. You do 30 seconds of deep breathing, you'll put yourself in this blood gas right now. If you keep doing it too much, your body says, oh, no, and puts you in shutdown mode, right? And then you'll pass out. You'll start getting tingly fingers and stuff like that. Your body's saying, no. But you can get this CO2 by taking 10 really deep breaths. And it will throw your pH off like this. And that's why CO2 can change really quickly. But you'll see this a lot with the blood gas. Somebody's gonna get their chest essentially cracked open tomorrow in open heart surgery. And so I'm gonna come in and draw a blood gas. Yeah, you might be a little anxious. All right, I get it. I would be too. So they see it's blood gas and the physician's like, that's fine. Because they were just hyperventilating a little bit. So, uncompensated respiratory alkalosis. But it's good to know the definition of it. Now, one last one. And then we'll, if you have any questions, let's see. Seven, 4, 5, 35, 90, and 25. What do you think? What'd you say? Perfectly normal, man. Right on. Good job. So yeah, don't overanalyze it. This is like 90% of blood gases are normal, but it's still good when you're doing your clinicals to go and look. If your patient has a blood gas in there, look over it each time. Even if they're not, even if the numbers aren't red, go through and do that little read because most of them are normal, but you got to know what normal looks like to know how to take care of abnormal. So this is normal because this is normal range. This is normal range. Although they're on into the range, the body has a buffer. I mean, so they're doing what's supposed to do. And so that's a normal blood gas. So don't try to overanalyze them. Although I will sometimes. Like, oh, well, that's kind of on the low end of normal. So I'm reading a little fast. Maybe that's more like an 18 than a 16. No, you don't overanalyze it. There's majority of blood gases we do are absolutely normal. So, any more questions? Okay, cool. So the plug for my page, you go to YouTube, type in RT Clinic. Every one of my videos start with RT Clinic. Like, subscribe, comment, hit the little bell thing. Cool. I have 1,800 subscribers, and as of January, I started getting paid on YouTube. So I'm a premier. Yeah. Cool. So I'm a partner with YouTube, and I just did a video on there for a respiratory therapy college in Saudi Arabia who had some problems with checkoffs. They sent me their checkoffs. I did some of their checkoffs on a video and sent it to them. So I got a partnership with Saudi Arabia. It's kind of cool. That's what YouTube gets you. Anyway, you can comment on there. You can make fun of my bald head. I don't care what you do. Just share it with your friends. And if there's other videos you guys want, I try to put out one a week. I have 2 kind of rolling right now I need to put out, and then I'll throw this one out too. So, yep.
Thank you so
Yep,
much.
thanks.